also like techniques. Cut the beard along with the lateral advancement or something. So Dr. Leoni, sorry to keep you waiting. Please go.
Okay, thank you, sir.
Carry on.
Thank you very much to all of you. It's a great pleasure and an honor to be here. So my talk is on congenital blepharoptosis, and we all know there are lots of controversies on congenital ptosis, so I'll try to focus on the 5 most important ones. So first, the timing of surgery. When do we operate on these children? Second, the choice of operation. Is there a best operation for any of these children? 3, do we change our surgical option if we are in front of uni or bilateral ptosis? 4, which is the best choice in Marcos-Gangio-Winking ptosis? And finally, is it better a one-step or a multi-step surgery when we have ptosis and squint at the same time? So first, the timing of surgery in unilateral congenital ptosis. So we know that there is a difference between these 2 children. On the left-hand side, you see a 12-month-old little girl, and it's already too late to operate on her when you have amblyogenic ptosis. And there is a difference on the boy on the left-hand side, because you see there is an anomalous head position, which is suggestive of well-preserved binocular single vision, so we can wait a little bit more time. So for the first case, what we have to do is to operate possibly in the first 3 months of life, and the best options, in my opinion, is still unilateral brow suspensions with known autogenous, known integrable material. We have to overcorrect the eyelid a little bit, as you see in this case. We have to tell the parents of the patient, this is not cosmetic surgery, this is pure functional surgery. We have to preserve the sight of the patient. This is an anti-amblyogenic correction of ptosis, and so we gain time until the child is a little bit older to do definitive surgery at another stage. What is a relatively new concept of the last 5 to 10 years is that even in mild cases of unilateral ptosis, like in this child, we might have anisometropia, regional myopia, and amblyopia that may be not initially apparent, but they progressively develop during follow-up. And what is even more important, they may regress following surgical treatment. And this is the reason why recently, for unilateral congenital ptosis, we started to operate a little bit earlier than usual. And we reviewed our cases recently, and we found out that the best results were when we operate these children between the age of 2 and 4, which is A plus B, as opposed to children older than 4, C, D, and E. So the results were significantly better, both in terms of functional result, cosmetic result, and decrease of postoperative lag of thalamus. And we see some of our results. So this child was age 2, 3, 2, 2, 3.5. And we went a little bit further, and progressively we start to study the muscle, so the quality of the specimen of the levator muscle we excised, we resected the surgery. And we found out that when the children were very young, the muscle might be very thin, but there was just a little tiny degree of fibrosis, as opposed to older children where we either have very thin muscles or very thick muscles with fatty degenerations and lot of fibrosis. So the choice of operation. Is there any room for Mueller's muscle resection in children? There is, if you see a youngster, a teenager who had a congenital ptosis and there is a positive phenylephrine test. In this case, of course, you can use Mueller's muscle resection. And again, aponeurosis surgery. This is good when you have a true blepharochalasis syndrome. And my advice is to perform bilateral surgery and to operate these teenagers quite young to obtain symmetry and good results. Posterior levator pexy was suggested by my friend Ramon Malhotra for any kind of levator function. In my opinion and in my hands, it's quite good when you have a reasonable degree of levator function and you want to operate on oriental children to get a very soft skin crease, like in this case. And the other two types of operations, brow suspensions and frontalis flap, let me introduce the third controversies. So do you have another option when you have bilateral ptosis? In my opinion, frontalis suspension and frontalis flap are very good for bilateral ptosis. I avoid, unless exceptions, this kind of surgery of unilateral ptosis because you have very bad asymmetry in down gaze. But whenever you have bilateral ptosis, the best option is still probably brow suspensions with autogenous fascia lata, or more recently, frontalis flap surgery. We all know that even if you are an excellent surgeon, you might end up with a bad scar on your leg. This is just what happens if you harvest autogenous fascia lata. So another option might be donor fascia, which can obtain very easily in Italy. And in my experience, long-term results are exactly the same if you use donor fascia or autogenous fascia lata. So no big differences. And so fourth controversies, which is the best option in Marcus Ganjo winking ptosis? So probably you do nothing if there is mild ptosis or no ptosis and mild jaw winking. No treatment is needed. What would you do if there is a reasonable ptosis and there is an evident jaw winking, like in this case? Then you can ignore jaw winking. You just advance the aponeurosis. This is what you get. And of course, you have to tell this young patient in his early 30s that the jaw winking will get worse following a treatment. So this is the jaw winking following treatment. This is what it was before, but the patient will be happy with its ptosis correction and will just avoid crunchy food in front of his partners. Please avoid levator resection because this is very bad, gives bad results. If you have evident ptosis and evident jaw winking, then you have to go for bilateral treatment with autogenous fascia lata, but the levator excision might be effective even if you do it only on the affected side. Any space for unilateral treatment, this is accepted and suggested when you have associated anomalies of the affected eye, like in this case. This was a spontaneous perforation, so what we did, it was evisceration ball implant, autogenous fascia lata harvesting, and ptosis correction, and results are good even after some 10 years. And for unilateral cases, frontalis flap might be an option because in my experience, asymmetry is down gaze is better than when you do unilateral brow suspension, like in this case. What do you do if you have associated strabismus and ptosis at the same time? Can you do it together? You can. If you do a NAP procedure, you save time and you avoid exposure to repeated GAs. So in the end, please treat early. Prefer unilateral levator resection in unilateral ptosis before the age of 4. Brow suspension or frontalis flap surgery in bilateral ptosis. Brow suspension in unilateral ptosis only for temporary correction in the first months of life. Frontalis flap in unilateral ptosis, best options. Third nerve palsy with no residual levator function, or Marcus Ganjo winking syndrome if bilateral treatment is refused. Thank you very much for your attention.